Assalamu alaikum. Good morning, colleagues, ladies and gentlemen. And thank you really very much for giving me this great opportunity to discuss and to get your feedback on our regional initiative for designing and implementing of the PHC-oriented model of care toward transforming our vision into action. Colleagues, 90% of the recommended intervention for universal health coverage can be delivered through the primary health care. Let me please repeat this again. 90% of the recommended intervention toward achieving of universal health coverage by the year of the 2030, we are talking about 7 years from now, are available and provided at the level of the primary health care. So the question is, where is the primary health care and where is the primary care facilities and the service provided? Almost after 45 years from Alma-Ata and 5 years from Astana. I'm sure that all of you are familiar with the very limited quality of the services at the primary care facilities in many countries in our region for different reasons. Colleagues, 90% of the allocated budget for the health sector are directed to the hospital care, and the primary care just receive less than 5%. Again, more than 90% of the primary care facilities in our region doesn't follow any quality measures, in addition to a long list which actually pushed the private health sector in many countries to take the lead with very high out of pocket. During COVID pandemic, our region, for the Eastern Mediterranean region, was the highest globally in declining of the routine immunization coverage, with almost 70% disruption of the primary care services. So colleagues, my point is that if we are going to focus only on the budget or the quality only or the effective engagement with private health sector, this definitely will not take us anywhere. We are in need to work on developing of the country's PHC-oriented model of care as a regional initiative toward transforming of our vision into action. That's why last year you kindly endorsed our resolution with the 7 regional priorities for building of the resilience health system and health security. And the 3rd regional priority was about the PHC-oriented model of care. Oriented model of care, it is actually the first operational lever in the PHC operational framework for Astana Declaration, for moving of Astana Declaration and the 3 components of the primary health care into action. But what do you mean exactly by this PHC-oriented model of care? It's a kind of new concept, so each of us has his own definition. Colleagues, PHC-oriented model of care, it is about the way of the services has been selected, designed, organized, managed, and how it's going to be supported by the different service delivery platforms. Based on this definition, each country in our regions, they have some sort of model of care. Usually, it is fragmented, hospital-oriented. Has to be, of course, hospital-oriented. 90% of the budget go to the hospital. Parallel, multiple, but it never to be an explicit model of care. We have almost 22 implicit model of care in our region. For designing and implementing of the PHC-oriented model of care, we have 6 key elements. 4 out of these 6 are more or less related to the package. That's why we always say that having the package, it is a top priority for us. And it is the first step for designing and the implementing of the PHC-oriented model of care. In the coming few slides, I'm going to share with you how we operationalized these 6 elements in the field in 2 districts, Sharsada and the ICT districts in Pakistan. This is the largest country in terms of the population in our region. First step is to have defined essential health service package with clear population. And this package has to be endorsed, approved from the country. And this is the case for Sharsada and the ICT in Pakistan. Second is to adopt the service delivery arrangement to the newly approved endorsed package. How we did this? The first step, we signed MOU, Memorandum of Understanding, with a number of the universities about the diploma in family medicine. And we enrolled the public physicians, the GPs, in this diploma. Actually, some of them, they already graduated and working in our facilities. In addition to train this physician and the nurses there on the disease management, including communicable disease, non-communicable disease, mental health, TB, malaria, and so on. But more and more important is about the implementation of the patient safety and quality care. Minor renovation, in addition to provide the facilities with limited list of equipment to meet the expectation according to the interventions available at the newly endorsed approved package of services. Colleagues, for the first time in Sharsada, they have almost 3,000 family folders. And for the ICT, they have already electronic management system. Integration of the health programs, how we did this? Through the family physicians. I asked one of the newly graduate family physicians about before and after her graduation and joining our program. What's the difference? She said that almost 180 degrees. It used to be her approach for the service provision. It used to be individual approach. And now it became family-based integrated approach with very high patient satisfaction from the quality of the service. It ends that utilization, it used to be below 20 visits per day, and right now it became more than 120 visits per day in the 3 clinics. Colleagues, ladies health workers are playing a major role in Pakistan for establishment of the strong linkage between community health and the facility-based services. Colleagues, I'm really honored to present for the fourth and the last time in the RC. Over the last few years, I get the opportunity to present a number of regional initiatives, including the family practice approach, effective engagement with private health sector, and recently, regional professional diploma in family medicine. I have been in this field for the primary care for almost 40 years. Today is October 9th. Actually, this is my birthday. And I'm going to retire by end of this month. And my closing remarks for you colleagues that PHC-oriented model of care is really top priority for us for building of the resilience health system and health security in our region. Thank you very much. Looking forward for your very valuable feedback on our regional initiative. Thank you.
Thank you very much, Dr. Hassan, and happy birthday to you.
Thank you. Thank you.
Really, this is such a nice presentation and nice way to celebrate your birthday, I'm sure. Nothing more fun than presenting on primary health care, something that you have worked in for, like you said, for the past 40 years and have enjoyed very much doing. Before we go to the discussion, we have two interventions through video that we're going to share with you. The first one is from Dr. Zaim Zia, and I ask Karim to please, yeah.
Dear colleagues, Assalamu alaikum. After becoming a signatory to the UHC Global Compact in 2018, the government of Pakistan is committed to achieving the universal health coverage and taking necessary measures in this regard. I am glad to share that Pakistan is the first country in the world which has developed UHC benefit package essential package of health services based on DCP-3. The support by the DCP-3 Secretariat, World Health Organization, and development partners has played a significant role in this landmark achievement. As Pakistan began to operationalize the EPHS in 2021, the critical challenge was to mobilize resources for implementation under the prevailing economic situation in the country. We are very thankful to World Health Organization, which basically facilitated government in organizing and leading high-level PHC for UHC mission in March 2021 for the situation analysis and advising the government on implementation of UHC through the PHC strengthening. Also mobilizing the catalytic funding for pilot PHC-oriented model care in 2 districts, including Islamabad and Charsadda. The substantive focus of the model of care implementation is UHC benefit packages, prioritized interventions through holistic health and intersectoral approach for provision of integrated health care to the targeted population. The key intervention were targeted at strengthening the community engagement and launching the family practice approach at the primary healthcare level for health education and promotion and health service delivery in line with the UHC benefit package interventions for improving the population and population health in target districts. Under the FPA, we targeted on training of the PHC medical practitioners through diploma in the family medicine, training of the primary healthcare workforce on standard training module developed with the support of the World Health Organization, and also incentivizing more universities for establishing faculty of family medicine for training of the healthcare providers. The family practice approach changed the service delivery model from patient-based services to family-based services, through which the referral is also improved. This model of care project has helped us build a multidisciplinary capacity of health workforce, particularly the primary healthcare level, for provision of the services for communicable, non-communicable diseases, RMNCH, immunization services, and also for establishing a referral linkages for higher service delivery platforms. I'm glad to share with the August audience that the phase 1 of the Model of Care Initiative 2021-23 has been successfully completed and its evaluations are ongoing. We are hoping to present it as a good model of replication in other districts during the expansion. We are thankful to the World Health Organization that they have confirmed that their funding for the expansion of the initiative has been secured until 2024, and we are already engaged with the stakeholders for planning and implementation of phase 2 in existing and 2 new districts. Dear colleagues, the government of Pakistan appreciates World Health Organization for providing all the technical support, coordination and guidance in the implementation of the PHC model of care. I am confident with this progress and dedication, will be able to transform the quality of service and patient satisfaction through the provision of the integrated services. Thank you very much.
Well, I should thank Dr. Zaim Zia, and we have another video that will be presented by Dr. Sangeeta Dami. Can we have the second video, please? Yes.
Assalamu alaikum. My name is Dr. Sangeeta Dami, and I've recently had the pleasure of visiting Pakistan as part of the WHO mission to evaluate the implementation of the models of care framework that has recently been implemented there. First of all, I'd like to extend my thanks to colleagues in Pakistan and the WHO Pakistan Country Office for their generous hospitality and the care and effort they took in allowing us to visit various centres in Pakistan and to get a good overview of the developments that are taking place. My overall impression was that progress is welcome in many respects. Clearly, the country is committed to a primary health care agenda. There is important work taking place across Pakistan, particularly in Islamabad and Charsadda, the 2 pilot areas for the implementation of the models of care framework. I was really pleased to see the commitment of staff, the facilities that have been developed, and the fact that there is now a proactive longitudinal care beginning to be practiced, extending now to chronic disease conditions. That said, there are still a number of areas for improvement. The key ones I would like to highlight include the need to think about catchment areas, empanelment, developing long-term relationships between patients, families, and their healthcare professionals, and then implementing guidelines and care pathways for the big ticket conditions that are prevalent in Pakistan, which mainly include the chronic health problems that Pakistan is now suffering from, namely hypertension, ischemic heart disease, hyperlipidemia, and the chronic respiratory conditions that are now prevalent there. This will need to include referral criteria, methods to ensure accurate exchange of information between the primary care clinics and hospital services, whether this be in the public or the private sector. I would also like to highlight the need to develop relationships cross-sectorially. That will allow public health measures to be implemented. As we know, these are important for improving outcomes for long-term health conditions, namely things like tax on sugar, tobacco, access to green spaces, etc., which would all help in terms of chronic disease problems. In summary, Pakistan is making welcome strides. I think there is a lot that we have been able to learn from Pakistan, and other countries in the region should also be able to learn from these lessons. Clearly, there is a way to go, but I am convinced that the leadership and infrastructure are committed to delivering a secure, primary healthcare-led future
two very
for
important
Pakistan.
videos
Thank
that
you.
reflect on the situation in the Pakistan that you were describing. We now open the floor for discussion. So it's time. I think primary healthcare is a very important topic. All of us, okay. So I see, okay. Let me, okay. I'm younger than Hassan, but I need my glasses. So I'll see Somalia, Iraq, Yemen, and I can't see the Kuwait. And then we'll take from the floor. So we first take a floor here. Somalia, can you please start? Dr. Jama.
Yes.
Yeah. Okay.
Yes. My name is Dr. Mustafa Awil. I am the Director of Family Health Department, Federal Ministry of Health, Somalia. I would like to thank the Secretariat for this technical paper highlighting the latest knowledge on implementing the primary health care oriented models for care and its potential contribution towards advancing universal health coverage. Primary healthcare approach is a foundation for achieving universal health coverage. Somalia Universal Health Service Coverage Index stands 27 on a scale of 0 to 100. This is significantly lower regional average of 46, or the global average of 60.5. Despite these challenges, Somalia is committed to expanding access to primary healthcare service. To achieve this, we undertook a critical step of redesigning the essential package of health service, that's the EPGS, to improve universal health coverage. The UHC Service Package of 2020 is a framework of organizing, managing, and delivering primary healthcare services to our population. One of the key characteristics of EPHS, its approach, is integrated, people-centered delivery primary healthcare service. It is therefore imperative that the various disease-specific interventions and initiatives funded by our partners to be integrated into the primary healthcare delivery model for better efficiency. Thank you.
Thank you very much, Dr. Mustafa, for sharing with us. Now, Iraq, please.
Thank you very much, Mr. Chair. Ministry of Health has paid great attention to providing screening and affordable health care services at all levels. Essential care is introduced as an integral part of UHC benefit package. The essential list of medicine and technologies for all primary health care service is operationally available. National management guidelines are updated and health for folks trained services are introduced into all public health programs. Essential health care is also provided for settled IDPs and in camps and institutionalized people. Despite the role of private sector, there is limited feedback and lack of partnership with public sector. Sustainability of healthcare requirements still constitute a major challenge in achieving UHC targets. monitoring and evaluation of PHC readiness. And national essential medicine list assessment are undergoing in collaboration with WHO. But still, the issue need political will to transform the vision into action. Still, public healthcare oriented model is the most subject that talk about, and unfortunately, the least one walk on the ground. Thank you. Thank you.
Okay. Thank you very much, Iraq, for this intervention. And now we go to Yemen, please. تفضل.
Thank you, دكتور مها. Thank you, دكتور حسن. بسم الله الرحمن الرحيم. رغم التحديات اللي تواجه النظام الصحي في الجمهورية اليمنية، استطعنا أن نحافظ على النظام الصحي من الانهيار بدعم من الشركاء، بدعم من البنك الدولي، مركز المال للإغاثة والأعمال الإنسانية. كما تعلمون هناك 51% مرفق صحي فقط يعمل بشكل كامل في الجمهورية اليمنية، حوالي 49% تعمل بشكل جزئي أو لا تعمل، ولكن استطعنا أن نفتح حوالي 3400 مرفق صحي مزودة بخدمات الانتجريتد هيلث. هذا العام 300 مرفق صحي بدعم من البنك الدولي والFCDO عبر منظمة الطفولة اليونيسف. حاليا الآن نعمل على أكثر من 300 طبيب يعملوا في 300 مركز صحي، يقدموا الخدمات في 300 مركز صحي. المرافق الصحية التي هي مغلقة ولا نستطيع أن نعمل على فتحها نعوضها عبر الموبايل تيم أو الأوتريتش. نعمل 6 راوندز في العام، بتصل إلى الIDPs، بتصل إلى المناطق أو الذي لا يستطيعون الوصول إلى المرافق الصحية. نأمل إن شاء الله خلال الفترة القادمة والعام القادم بفتح مراكز ومرافق صحية بدعم من الداعمين، سواء مركز الملك سلمان للإغاثة والأعمال الإنسانية أو التحالف العربي بشكل عام، والبنك الدولي عبر منظمة الطفولة اليونسف ومنظمة الصحة العالمية. كثير من التحديات تواجه النظام الصحي، ولكن استطعنا خلال المرحلة الماضية. طبعا كما تعلمون البلد منقسمة، جزء هنا وجزء هنا، ولكن نحاول أن يكون النظام الصحي بعيد عن كل الصراعات بدعم من الشركاء. مرة أخرى شكرا لمنظمة الصحة العالمية ومنظمة الطفولة اليونيسف في مساعدتنا بالشكل الفني لتقديم كثير من الخدمات. شكرا جزيلا.
شكرا دكتور على المداخلة. الشكر. دلوقتي معنا الكويت. Sorry, we have now Kuwait followed by Tunisia.
Thank you, Chair, for giving me the floor. And thank you, Doctor, for your lovely and comprehensive presentation. Wish you all the best after your new chapter of life after retirement. I would like to commend the efforts put in the preparation of document designing and implementing primary healthcare-oriented models of care in the Eastern Mediterranean region. The discussion and contents are very relevant to our region. It's encouraging to learn WHO EMRO's initiative to develop context-specific primary healthcare-oriented model of care, given the diverse context and disease burden and population needs across the region. In Kuwait, commitment to universal health coverage is reflected in various policies, including major role taken by the primary healthcare system, not only in service provision, but also for patient education and capacity development of medical professionals. We are providing essential medical services through over 115 government-run primary health clinics across all 6 governments, including preventive care, dental care, maternal health care, general health, child care, and non-communicable diseases, supporting capacity building in family practice in the region through the provision of training to family practitioners in the countries of the region, involving stratum of our society to respond to the population's specific needs via healthy cities and other community-based initiatives. Our region, with its distinctive socio-political landscape, warrants increased focus on approaches that are specific to the local context and are mainstreamed across sectors to ensure that families, youth, and care practitioners are empowered. This emphasizes the necessity for a robust and tailored primary healthcare-oriented model more than ever. Kuwait also would like to emphasize our continuous commitment to regional collaboration by sharing our experience and expertise in developing and strengthening primary healthcare models with other member states in the region, while we remain steadfast to the whole of society approach for health through primary healthcare that aims at ensuring the highest possible level of health and well-being, and it's determined to create an empowering environment for all its citizens. Thank you.
Thank you very much, Kuwait. And now the floor goes to Tunisia, followed by Lebanon.
Shukran. Je m'excuse, je vais parler en français parce que j'ai pas préparé une intervention formelle, mais c'est un sujet tellement crucial que les idées viennent spontanément, surtout avec l'excitation de Dr Salah. Il nous pousse à réfléchir et profondément à ce sujet-là. Donc, en Tunisie, on considère que notre système de santé primaire, il est assez développé depuis les années 2000, notamment grâce à la notion de circonscription sanitaire, qui est une entité géographiquement bien limitée et avec des programmes de santé déjà définis et un paquet de services déjà définis. Donc, et une population desservie qui est aussi bien définie. Mais reste le problème de l'intégration de la médecine de famille actuellement. Parce que sincèrement, il existe une grande confusion entre la médecine générale et la médecine de famille et on souffre pour introduire cette nouvelle notion avec l'approche holistique, l'approche centrée sur le patient et même la formation qui est recommandée et qui est vraiment une bonne chose, mais on doit préparer un écosystème et un environnement favorable à l'exercice de la médecine de famille. Les structures sanitaires actuelles, telles qu'elles sont et telles qu'elles fonctionnent, elles ne favorisent pas l'exercice de la médecine de famille. Il y a une très grande dépendance. Il faut, premièrement, il faut décentraliser. Il faut que le gestionnaire de la médecine de famille ou de la circonscription sanitaire ait une certaine autonomie, une autonomie financière, une autonomie de prise de décision. Et surtout, il faut développer la recherche en première ligne. C'est un domaine qui n'a pas de recherche. Si on n'a pas de recherche, on n'a pas d'évaluation, on ne peut pas progresser. Donc, il faut créer des entités. La notion de recherche dans le cerveau et dans le quotidien du médecin de famille. Parce qu'actuellement, sincèrement, on est là pour prodiguer des services de santé curatifs. Et il n'y a pas de planification, il n'y a pas de vision. Et on ne participe pas aussi, on ne nous implique pas en tant que médecin de première ligne dans la prise de décision et dans la planification. Merci.
Thank you very much, Dr. Sina, for your intervention. And I think it is a very important issue of actually the image of the family doctor and the role in the society and how they are perceived in the community for people to reach out for them and the need to beef up, so to speak, the career and the developmental path. I saw Lebanon. Helga, please.
Thank you, Madam Chair, and thank you, Dr. Salah, for highlighting once more the importance of primary healthcare and primary healthcare-oriented models of care. Happy birthday and happy retirement. Lebanon is now passing through dire economic situation, mainly visible through the devaluation of national currency. We have GDP falling by 40%, where it is estimated that more than 50% of the population fall below the poverty line. 41% of the household report challenges with securing food, and 40% of the health workforce have left the country. However, we always believed that times of emergencies present excellent opportunities to grow. In the latest multi-sector needs assessment survey, the utilization of services in hospitals have decreased. The ancillary services decreased as well, and the medical consultations. But primary healthcare services have increased, and 22% of people reported switching to public healthcare facilities. 76% of people switched to drug substitutes, mostly available in primary healthcare centers. We believe that grabbing this opportunity through improving quality of care at primary healthcare centers through revisiting the health packages, primary healthcare packages, and bringing more involvement of family practice through official contracts and the training of PHC personnel would be timely. And as always, we lean on the continuous support of WHO in our initiatives. Thank you.
Thank you very much, Lebanon, Dr. Hilda. And now we have 3 more countries that raised in the order: Morocco, Saudi Arabia, and United Arab Emirates. So we start with Morocco, please. Have the floor.
Merci, Madame la Présidente, chère assistante. Merci, Dr. Salah, pour votre présentation qui a mis en valeur l'importance des soins de santé primaires, mais aussi son rôle dans l'achèvement de la couverture sanitaire universelle. Le Royaume du Maroc, depuis l'indépendance, il a opté pour un choix politique de mettre en place une gratuité des soins de santé primaires pour toute la population, avec plus d'une quarantaine de programmes de santé publique et aussi l'accès aux médicaments. Et ceci a permis à la population de réduire un nombre important et d'éradiquer des maladies aussi transmissibles. Et du coup, le Maroc, avec l'appui de l'OMS et plusieurs partenaires financiers et techniques, a opté pour plusieurs programmes de coordination, notamment le repositionnement et le renforcement du système de soins de santé primaires dans le système national de santé. Et ceci s'est marqué par la formation des professionnels de santé, mais aussi bien par la participation communautaire de toutes les circonscriptions sanitaires. On dispose plus de 3000 centres de santé entre urbain et rural, premier niveau et deuxième niveau, mais aussi le rôle que peut jouer les soins de santé primaires dans notre système dans le cadre de l'achèvement de la couverture sanitaire, parce que le Maroc a opté pour la généralisation de l'extension de l'assurance maladie obligatoire à toute la population, ce qui pousse à améliorer et refondre notre système de santé avec la création des groupements sanitaires de territoire, et dont le système de soins de santé primaire occupe une place importante avec l'instauration aussi bien de la médecine de famille, mais aussi de rôle de l'achèvement de la couverture sanitaire universelle pour toute la population. Merci.
Merci. Thank you very much, Morocco, for your intervention. And now we have 3 more countries. We have Saudi Arabia, United Arab Emirates, and Egypt, to be followed by non-state actors. So Saudi Arabia, you have the floor. Please, تفضل.
شكرا لكم. نشكركم حقيقة على الورقة التقنية وكذلك العرض المقدم بخصوص نماذج الرعاية الموجهة للرعاية الصحية الأولية في الإقليم، ونثمن كذلك الجهود المبذولة في هذا السياق. يأتي تقديم نموذج الرعاية الصحية الحديث مراعيا لحاجة الخدمات الصحية في المملكة لتحقيق خطط برنامج التحول الوطني لدينا وأهداف رؤيتنا 2030 في المملكة، حيث يهدف إلى تقديم الرعاية الصحية للمستفيدين من الخدمة بما يكفل أعلى مستويات الجودة والكفاءة للمستفيد، كما يقوم بتحقيق مفهوم الوقاية ويوفر البيئة المهنية الأمثل للممارس الصحي. ويرتكز هذا النموذج على الرعاية الصحية الأولية، ويتم تطبيقه بمفهوم طبيب أسرة لكل أسرة. وقد صمم نموذج الرعاية الحديث استنادا إلى أنظمة الرعاية 6، وهي الرعاية الوقائية، الرعاية العاجلة، الرعاية الاختيارية، رعاية النساء والأطفال، رعاية الأمراض المزمنة، والرعاية التلطيفية. وعلى الرغم من وصف نموذج الرعاية بكونه نظاما صحيا شموليا يلبي الاحتياجات الصحية، إلا أن تنفيذه يتطلب دعم العوامل الممكنة للتطبيق، والمتمثلة في مشاركة القطاع الخاص وتمويل الرعاية الصحية والحوكمة والأنظمة والصحة الإلكترونية والقوى العاملة. شكرا لكم.
شكرا لك. Thank you very much, Saudi Arabia. Now we move to United Arab Emirates. Dr. Hussaina, تفضلي.
Assalamu alaikum. Thank you, Chair. First, I'd like to thank the Secretariat for developing this report, and I'd like to thank Dr. Hassan for this great presentation and wish you a happy birthday and great retirement. And PHC is very close to my heart, being a family physician. United Arab Emirates has adopted the model of primary healthcare services as part of its continuous program of health sector, and the package of health services provided currently at the primary healthcare level represent the basis for achieving universal health coverage in the country. Services are provided through health facilities and institutions within the UAE health system, and most of them are JCI accredited and being provided by by family physician. And these services include home care services, healthcare services in workplaces, such as schools, universities, factories, airports, and basic and advanced primary healthcare services in primary healthcare centers and family health promotion centers, advanced primary healthcare services in community and general hospitals, both government and private sectors. Ministry of Health and Prevention has issued several health services protocol that define and detail requirement of health services at the primary healthcare level that cover the entire population nationwide. The guideline and protocol cover the areas of mother and child care, elderly care, control of communicable and non-communicable disease, mental health, and emergency preparedness and response. And these guidelines implementation are being monitored by the KPI. Spending on primary healthcare constitute about 45% of the total spending on health during the year 2021. And most of these services were financed through the government budget and health insurance scheme covering employees in both public and private sectors. In addition, to ensure the highest level of commitment and participation of all health partners and stakeholders in the country, a ministerial decree was issued to form a national committee to review the priority health benefit packages that respond to the health needs of the population, calculate the cost of the package, and then find appropriate mechanism to finance those services. Noting that primary health care services are currently provided in accordance with the national curricula and guideline. They present the basis for the range of intervention purpose for benefit packages. The cumulative experience, health care department, and authorities at the local level were also used to develop target primary health care models that suit the health needs of the population in their areas. And recently, the Priority Health Benefit Package project to achieve universal health coverage has been selected as one of the government transforming projects, and that will guarantee political and financial support and follow-up from higher level of management in the country to achieve our target toward universal health coverage. Thank you.
Thank you very much, Dr. Busaina. Now, Egypt, please.
Thank you, Dr. Maha. Thank you, Dr. Hassan, for your eloquently delivered presentation, and happy birthday. Your Excellencies, ministers, distinguished colleagues, ladies and gentlemen, Egypt reemphasizes the paramount importance of primary healthcare as the cornerstone of healthcare excellence in achieving universal health coverage. Egypt, as a concrete country example, demonstrates the political and technical feasibility of reorienting the health systems towards PHC. With a clear vision for the healthcare accessibility, Egypt has embarked on a journey to enhance through another strong presidential initiative designed to strengthen our primary healthcare system comprehensively in 3 years. Through 5,400 PHC facilities around the Republic, Egypt delivers a wide range of essential healthcare services to its communities. These services touch upon maternal and child health, treatment of common illness, nutrition counseling, family planning, health promotion, NCDs management, basic emergency care, referral, and coordination. Egypt's unwavering commitment to PHC principles is evident in its comprehensive approach, including the expansion and renovation of primary healthcare units, hospitals, clinics across our nation. We're building the capacity of our healthcare providers, such as doctors, nurses, dentists, pharmacists, through an intensive training program. Specialized clinics have been established within the primary healthcare units to meet specific healthcare needs, complementing basic services. We have also streamlined healthcare management and allocated substantial financial resources to fortify our healthcare financing. The COVID-19 outbreak showcased the pivotal role of PHC facilities in crisis management. We actively utilize PHC facilities, established a crisis management committee to help in that regard. Intersectoral collaboration is paramount. We cannot stress enough the importance of collaborative action. Cooperation with international organizations like WHO and other agencies has played an imminent role and vital role in addressing the evolving needs of our healthcare workforce. Our commitment to PHC aligns with our long-term vision for healthcare investment. The presidential initiatives aim to elevate healthcare service quality, expanded access, and enhance the health and well-being of our citizens while advancing sustainable development goals. Infrastructure expansion, healthcare workforce training, specialized clinics, improved healthcare management, and increased healthcare financing are key aspects of this initiative. At the end of the second stage of the initiative, which is a 3-year initiative, Egypt will have 1,400 primary healthcare facilities within the system, representing around 25% of our healthcare facilities, of our primary healthcare facilities. In alignment with this strategy, Egypt is aligning its direction with the One Health strategy and the Health Map strategy, which were unveiled during the Global Congress on Population Health and Development last September. Furthermore, Egypt is committed to maintaining essential services during times of crises. PHC facilities have adapted to the new normal by implementing measures such as redesigned waiting areas and optimizing patient flow. In conclusion, Egypt's commitment to PHC is a testament of our dedication to advancing universal health coverage and development goals, particularly those related to health and well-being. Thank you.
Thank you very much, Egypt, for your intervention. I don't see any other countries with the name stand up, so I will ask Dr. Ibtihal to present herself and to make her intervention, followed by Dr. Tawfiq Khoja.
Thank you, Madam Chair, and thank you, Dr. Salah. I'm presenting the NCD, the Regional NCD Alliance and the Global NCD Alliance. Thank you, Dr. Salah, for the great presentation and for highlighting the need to invest in strong primary health care. As we know, primary health care play a great role in equitable and quality and safe NCD services, from promotion to palliation. The Regional NCD Alliance, working with the local and global partner, including WHO, in strengthening primary health care, focusing on raising awareness, NCD prevention, and capacity building for healthcare professionals in primary healthcare, as well as engagement of people living with non-communicable disease. Ladies and gentlemen, the rising incidence of NCD in the region continue to test the resilience of the health system and prove that we are not well prepared to address the challenge. We are fully aware that many countries in the region continue to be challenged by this issue, and such as inadequately trained health workforce in the primary healthcare, timely referral and follow-up of patient, and inappropriate structure. As such, and representing the civil society, we will continue working with the WHO and countries to prioritize investment in primary healthcare infrastructure and ensuring that it is equipped with well-trained healthcare work professionals and effectively manage NCD. We will focus on promotion and promote health literacy and awareness campaign to empower individuals with knowledge and tools to prevent NCD and make informed decisions about their health needs. We support the implementation of the WHO framework for meaningful engagement of people living with NCD to deliver patient-centered primary health care, focusing on individual preference and involvement in their decision-making. We address access to primary health care service among vulnerable groups, including refugees and displaced population in our region. Thank you.
Thank you very much, Dr. Ibtihal Al-Fadel. And now we go to Professor Tawfiq Khoja, followed by Dr. Nabil Odomfil. And I think that will be the last intervention, as I see, so we can give Dr. Hassan Salah time to respond. So Professor Tawfiq, you have the floor. 3 minutes or 2 minutes, please. Okay.
Okay. Thank you so much, Dr. Maha and Dr. Hassan Salah. I am really pleased to hear from Dr. Hassan Salah this excellent approach of health system based on primary healthcare provision. My comment on fostering this model in the culture of reimagine the care delivery is two vital issues. The first one is how to prepare our system or healthcare system for what is ahead. This is a model, and do we consider these issues or not? Second issue, it is important to understand that the WHO play a major role in enhancing primary healthcare in the region. So I am urging the WHO regional office to build a package of monitoring KPIs for the progress of proper implementation of primary healthcare based on family practice or family physician. Thank you so much.
Thank you very much, Professor Tawfiq Khoja. Now, Dr. Nabil Odomfil, and this will be our last intervention for this session.
Thank you very much, Madam Chair, and thank you very much, Dr. Salah. Actually, I'm going to really have a different approach. I think really the development of primary healthcare over the past 50 years has really been the main achievement of WHO, from Al-Ma'ata to Health for All, for the social determinants of health. And I think the countries and the people owe WHO this transformation, this very important transformation. However, as we stand now and looking forward, I think health has really moved into doing very well in biologic medicine, that is curative medicine, has done even very well by introducing and recognizing mental health as well into primary healthcare. This was not present 50 years ago, and started to talk about the social determinants of health and family medicine. And I think the challenge would be to, if we could really develop indicators and KPI, as was mentioned by Dr. Hoja, for social health. I think social health will be the main thing that will really transform the population through primary health care to become healthy individuals, not only patients that need care. Thank you.
Thank you very much, Dr. Nabil Olonful. And this is a good end to the interventions. And now I now ask Dr. Hassan Salah to please respond. I don't want to say as quickly as possible, but let's say
sure.
You have
2 minutes.
No, 5 minutes.
Okay. All right, that's great. All right. Thank you, colleagues. Thank you very much for almost like 13 interventions. Let me just start with this. We are not creating a new initiative. We are simply trying to organize the current models of care in each single country among the 22 countries in a way to have clear package to start with, putting in consideration health workforce, finance, governance, infrastructure, and so on. So again, we are not creating something new. The countries here already have their models. But as I mentioned, it is kind of an implicit one. Just quick respond to our colleagues, Somalia, they already have an excellent package of the services now. And they can build on this and start to work on the PHC model of care. And I believe Somalia, they are going to present their experience in the package in Astana on the 23rd of October. We're talking about like 10 days from now. Iraq, they have already a great package. And I already worked in this package a long time ago. I believe it was like maybe 12 years ago or something like this. But again, the package is there. It needs just only to work on implementing it. As you kindly mentioned, that it needs some sort of political will, and we are going to support you in this. For Yemen, Dr. Dina Al-Asfour are working with Yemen on the emergency service package, and hopefully that we can get done during this year. Kuwait, we are using actually Kuwait as a model for the family practice approach, and we already organize several training programs there in Kuwait in the primary health care facilities there. For Tunisia, and for the first time during this year, more than 50 physicians, GPs, they already joined the regional professional diploma in family medicine. And again, Tunisia, they are going to present their experience in the 23rd of October in Astana. For Lebanon, yes, definitely, the private health sector is taking the lead. That's why let us just work on this PHC model of care. Again, Morocco, they are going to join the regional professional diploma in family medicine. As you can mention, almost around, say, 30 participants during this year. For Saudi Arabia, this is great news that you already started this PHC model of care in Saudi Arabia, and the same for United Arab Emirates. Egypt, you have a wonderful opportunity. You already have the package, political will. And in addition, of course, is the health insurance. So let us start together for this PHC-oriented model of care. This will be a wonderful opportunity. Dr. Ibtihal, I totally agree with you. The non-communicable disease is a core of the package in most of the countries in our region, but the problem that the challenges facing in its implementation at the level of the primary care facilities. I believe I covered all the interventions. Thank you, colleagues. Thank you very much, really. Well, thanks again for happy birthday to me.
Thank you very much, Dr. Hassan Salah, for your for your sponsors in a nutshell, addressing almost all the interventions that were made. Primary health care is a topic that is dear to most of our hearts, and we all know how important it is, and we all want to move forward. I remember one of my first assignments when I was doing MPH, it was called 10 years after Al-Ma'ata. Where are we? So this was 1988. And at that time, we thought, oh, by the year 2000 is still a very long way to go, and we will achieve it by the year 2000. Unfortunately, we are now in 2023. We have not all achieved what we were hoping for in 1978. I think what our country, all the member states and WHO and all the partners were hoping for. So this should not be a dream now. It should be something that we turn into reality. And like Dr. Hassan Salah said, this is not something new that we're presenting. It is just how to operationalize the issues related to primary health care. It's time to act. And it's, I don't want to say it's time to act now. It's actually time to act yesterday. And now is the time to really push and move forward very quickly. Thank you very much, all of you, for your interventions. Many thanks to Dr. Hassan Salah for a great presentation and wonderful responses. And again, on behalf of all the people in the room, a very happy birthday. Thank you and happy retirement.